I want to jump right in because I know this is a topic that many of us care deeply about and have really been focusing on over the past few years. But I wanted to give a little bit of context before I punt it over to Bev, because I really think that the COVID pandemic has certainly highlighted the harsh reality that the opportunities to maintain a healthy and longer life are skewed in the United States by income, race, ethnicity, and area of residence. And this injustice is not just the consequence of random chance in the distribution of disease, it's an injustice by design, with many factors that interact with each other to produce poorer treatment and outcomes for minority groups. On a patient level, some of those factors can include cultural beliefs about health and medical care by members of the minority group. It could be mistrust of the healthcare system, which is largely based on past discrimination, language barriers, and other difficulties in communication factors associated with race and ethnicity, which is why it is so important for us to invite patients and families to play an active role in shaping healthcare, in designing a system that's built for them, by them. I cannot think of a better person than Bev to really share some actionable steps so that we can all take in addressing ethnic and racial inequities in healthcare by engaging minority populations. So Bev, I'm going to turn it over to you.
Thank you so much, Makaya. And I'm going to just pull my slides up here. And oh dear, they've gone all the way back. Let's see how we can make that work very quickly. There we go. Wonderful. Thank you. Thank you so much, Makaya, for all the work you do and for creating this opportunity to have a conversation with you and the Foundation's grantees and others about this important issue of developing authentic, robust partnerships with patient and family advisors from minority communities, from those who live in poverty. And we need to see this as an essential strategy to address health inequities, structural racism, and social injustice. Certainly the COVID pandemic highlighted this need tragically across our country. And early in March, the Institute for Patient and Family-Centered Care recognized a need to help and to learn from health systems across the country about how were they partnering with patients and families in the midst of this pandemic. So these webinars are available to you free on our website, as well as the informal conversations that we facilitated to really problem solve and strategize together about how we can, in the midst of this pandemic, partner in essential ways with communities of color. We got so many questions before we even had the first webinar that we developed a FAQ sheet, organized the questions, more than 100 questions, into themes with practical ways that you could involve the communities you serve in COVID planning, implementation, and evaluation. And this is a handout today, and I hope it will continue to be useful, both in New York. We're eager to see the best practices coming out of New York, but also bring the best practices happening across North America to New York. This concept of partnering with Black and Brown communities and having robust advisors part of our process of transformation is really not a new concept in New York. If we go way back to the HIV/AIDS epidemic, there was an opportunity created by the US Surgeon General, who created the expectation that we as a nation should collaborate with women and families infected and affected by the HIV/AIDS epidemic. And in New York, Harlem and Bellevue, they developed incredible partnerships with childbearing women to shape and develop supportive systems of care. In this slide, you see Barbara, who is teaching clinicians how to provide a diagnosis of HIV in a much more supportive manner than she received herself. They were wonderful patient and family faculty members in those days. Also around research, advisors from Black and Brown communities were serving as essential partners in research. This was even, decades before BCORI. And we were asked to bring these women together to advise the National Institutes of Health on the next phase of the AZT research on pregnant women. The results had been so positive, they wanted to stop the research early, but they were worried about breaking trust with the community. And what we all learned then, and particularly the researchers, was that these women from the community had insights that would have benefited the program of research from the very beginning, and that they were incredibly helpful. Moving forward in the early 1990s, when there was an opportunity to build the first children's hospital in this area in the Bronx as part of Montefiore. From the very beginning, families from that community, largely African American and Latino, were essential partners in planning the design of the facility, but also shaping the organization or culture for practice for the Children's Hospital. And we learned so much from this mother of a child with sickle cell disease who talked about the need for useful information to care well for her child. And she kept talking about a family learning place. And those of you who know the Children's Hospital at Montefiore know there's a family learning place in the lobby. But why did these partnerships, why were they really successful? And what could each of you on the call today take away from that experience in New York? And it is leaders at every level supported, modeled, and really celebrated these partnerships with patients and families. So there was a clear expectation, you're not going to do the work without them part of the process. Then there was intentional planning to involve the diversity of the community that truly reflected the diversity in this work. And the third was the belief that everyone has the capacity to learn and to really invest in each of these advisors so that they could be effective and meaningful partners in the work. And it was always from a strengths basis that this guided the work, that they have the ability to learn, they have important expertise, insights, and perspectives to share. Just this week, so we're moving decades quickly ahead. It was actually last week. We had a wonderful conversation with the director for Pediatric Behavioral Health and Wellness at University of Rochester's Pediatric program. And she talked about the work that they're doing. They've had a long-standing family advisory board. And recently during the COVID-19 pandemic, they have held a series of wonderfully attended community conversations for parents caring for children with special mental health needs and the community itself. And they have a new grant to hold 4 more of these community conversations. And they explicitly wanted to recruit the family advisors to the new family advisor group that would shape these community conversations. And they developed a flyer, but they gave it to clinicians and said, we specifically want to have families of color, the majority of the advisors for these community conversations. And that's what happened. They have 4 advisors, 3 of whom are people of color. Another wonderful resource for you is a document developed by Latasha Rouse. And Latasha is an advisor. She first worked in a hospital around perinatal health. She's been an advisor at the state and national level. And she has developed this guide that's available through NYSHealth on strategies for building diversity in a patient and family advisory council. I think her 5 key points are really important. And I think one of the things, once you recruit, when you have a comprehensive strategy for recruiting advisors, you want to be sure to support inclusion and belonging. Sometimes, particularly advisors who live in poverty that may not have had as much formal education, think, what do I have to offer? But respecting them, tapping into their strengths and their insights, and helping them see that they do have an important role. And then certainly engaging interpreters as they are needed, and making sure that everyone, leaders, the community, know the impact of this collaborative work, but also know that these advisors need to know that they're making a difference. Here's some more tools. We worked with a doctoral nursing student, Kendra Jones, to develop this recruiting tool to help recruit more diverse patient and family advisors. And just a thought about virtual meetings of PFACs and other collaborative quality improvement and safety meetings happening in health systems and clinics. We're seeing that virtual meetings are having even higher attendance than other in-person meetings, and that what one person told me, even the quiet advisors talk more on our Zoom calls. And I think it may be, one, the attendance is greater because they don't have to travel and the hassle of transportation, but two, they're more comfortable talking from their kitchen or where they sit and chat with their colleagues. And so they speak up more. So just to give you a few additional best practices for these partnerships to be effective, and particularly around the time of COVID, they should be part of these teams, planning, implementing, and evaluating. And particularly in New York, as you're setting a wonderful example for the rest of the country, and as you come out of this, how you're doing this wisely and are in touch with the diverse communities most effective. I think many healthcare organizations have emergency operations committees, and leaders of those committees need to be connected to your patient and family advisory council. Certainly a major issue is around family presence and participation, and how you implement those changes at all spectrums across the continuum of care. Family and patient advisors need to be part of that process. And I know the foundation has been supportive of prison health programs. And another example where these advisors are very important is in citizen reintegration programs. We can talk more about any of these in our discussion time. And certainly, I hope that every clinic and health system in New York that is developing telehealth is going to do it in partnership with patients and families. Tomorrow we have a free webinar just on that topic. If anyone is interested, we're happy to share that link. And certainly we hope that they're involved in working with communications and the wording and the use of the hospital's website. I think an underused resource for building partnerships with patients and families is for the staff liaison, the coordinator, the facilitator with patient and family advisors should really develop a good partnership with the diversity, equity, and inclusion officers. They may not know the work of advisory councils. And so that is a key partnership that I think needs to happen going forward. And I certainly think that it's key as in this time of the pandemic, where we have also an opioid epidemic, that we need to identify and address barriers to participation. That's really going to be critical to be successful in the long term. I wanted to let you also know that we are very grateful to the New York State Health Foundation for a grant to work over the next 8 to 9 months on really identifying best practices in New York and sharing them nationally, and and the reverse, that bringing best practices to here in New York. So I hope that you will join us for free monthly webinars and pfcc.connect conversations. Mary Minetti is the project director, and please reach out to her with ideas. We have a number of wonderful national advisors on that team. And so in closing, I just want to thank so many of the advisors from Black and Brown communities who really have been inspiring teachers for me, for all of us at IPFCC, and many, many others. They have had such a wonderful impact and really brought about transformational change. Each one of these pictures has a story and very powerful, wonderful memories. Thank you so much, and back to you, Makaya. And
thank you, Bev. So we have a couple of questions coming through. Just a reminder, if you have any questions, now's the time to submit those in the chat box. One question for you, Bev, is a common practice in creating advisory councils is for applicants to undergo a background check, to check for any sort of criminal record. There have been some organizations, I think in the recent years, that have abandoned that requirement because they felt it may exclude a demographic that they wanted to be represented on the council. So the question is just, what are your thoughts on that being a required part of the application process?
That is a wonderful, thoughtful question. And I think it is a very good one to consider. We really believe where it came to the front for us and working with a number of different organizations was really in the opioid epidemic, and realizing that peer mentors were really important to the process of care, and that we needed to create ways to hire them to work in our emergency departments, to be outreach and support people. And this presented a challenge, the background check. And so what happened, here's a wonderful example of leaders can make things happen. So leadership talked to human resources. I'm thinking of a particular health system that is in New York, where they talked to the human resources, said, we need these people with a particular skill. These are the qualities and characteristics that we're looking for, and their lived experience is important to their being successful. That doesn't mean they don't have accountability and supervision, but the background check could be a barrier. So that's, I think, an example where we're going to have to partner with human resources. Sometimes it goes through the volunteer office and human resources, but I think it will take leadership to help bring about some changes in this.
Thank you. Another question is, do you have any advice for clinicians working with at-risk minority families right now, particularly in advocating with ACS regarding in-person visits for families in mandated services?
Very interesting. Again, I think that I probably am not the best person to give advice to clinicians. I think clinicians need to develop within their organization some opportunities to have some candid conversations with the patients and families they're serving, and to be able to talk about the challenges and really have an ongoing way to work on developing these relationships, because if we don't figure this out, we're going to create further health inequities.
Can you talk about the pros and cons of paying advisors for their participation?
Sure. And boy, this is often a hot topic, and I may get, a welcome. I can see the dialogue in the chat, so I welcome pushback too. That's how we all get better together. I know that when we first started doing the work, and we learned so much from patients and families, where we worked in the HIV/AIDS epidemic, it was with women and families primarily affected by the epidemic. And we said then, we will do whatever it takes to get people to the table. So that philosophy has been part of IPFC's work for a long time. They're people that have life circumstances where they don't need additional payment, that they can afford to volunteer. They have both the time and the resources. But there are many people, and my feeling is the people we need to hear most from to get our system of care working better is people who live in poverty, that live in underserved communities, and they can't afford to do this work without some kind of support. And I don't think it has to be even. I've had advisors tell me that you know, around the table, some people receive support and some people don't. But I think that many people having, whether it's a stipend, an honorarium, some people are creating, which is wonderful and we advocate for, paid positions, family leaders, patient leaders, and they would have a comparable salary for the work and the hours that they put in. Is that,
Yep.
is there any discussion in the chat that would?
No pushback yet.
Okay.
So I think this is a good question, particularly in light of, I think, some remarks you made and I made about mistrust in the minority community. So the question is, how do you build trust with your community advisory board, especially for engaging marginalized populations?
Well, there's a resource for you. We had a Bakori project that Marie Abraham in our office led a couple of years ago, and it was on building partnerships with underserved communities for serving as research partners. And I think that there's guidance there, there are video clips, it's wonderful. And maybe after, as a handout, we can give people the link to that. But the main part of what I took away from that was you have to spend the time being genuine in building trust in relationships. So I'll be very candid with you, Makaya, as I always am, but even on the air like this, I was worried about today that I wanted to make sure that my language was correct. And, you know, I think we all have to be vulnerable and say, we're in this together to learn and to admit, to be able to say, I'm sorry, to show humility that we need the diversity of patients and families we've served. We need to be honest with them and communicate and share part of our own vulnerabilities so we can build trust together. And I think also continuing to, you know, are we on the right track? Checking back with advisors, how can we be more open, more collaborative? What help us do better?
Thank you. Kind of going off of your point, Bev, about kind of the language that we use, the terminology. One question asks about how, if your organization has started to brainstorm new ways for thinking about diversity, equity, and inclusion, and whether or not, you know, that's an antiquated way of categorizing, so that we're not further alienating Black, Indigenous people of color.
Well, you know, one of the things I think to do is to start informally. I've always said this in terms of just working with anybody in building a robust patient and family advisor program. Bring people from the community together and say, this is the work we do in our organization. We know we can do better. We want you to help us. We're not agreeing to work together forever, but we want to get it started. And this may be the kind of work you'd like to do. But we may find that this isn't a good fit, or we need to. So just get people to the table and have some of those honest conversations and try to build something together. But it gives people permission. I think, you know, some people from Black and brown communities might come to that table and say, this this isn't worth my time. I want to work on this initiative. But I think you need to start together to have some of those conversations.
I think that's a great point. So the next question highlights, I think, an important issue that we sometimes overlook, and that is the experience that COVID-19 had on essential workers and them developing COVID-19 themselves or just, being exposed. So the question is there something that could be, is this something that your organization is looking at, since a lot of those workers, healthcare workers, were minorities and communities of color, how we engage them in partnering with patients and families?
That's very interesting. And I think I'd have to be candid that we are involved in a project that is starting in August that is going to be looking at people who've experienced COVID-19 themselves and how they would improve the system. But I don't think we've yet, I love this question. I'm looking forward to thinking more about these questions because I think it is an important issue. The whole issue of people of color serving in essential roles and how systems of care and support broadly could provide more support to them and involve them in this work going forward. I think there's work to be done, but I can't say that we are quite there yet, but I am delighted with hearing that question to be a prompt.
So I think one of the things that you highlighted in your presentation is just the importance of leadership engagement in this process. So I know you can't go over this extensively in the 1 minute that we have left, but any tips for mid-level leaders that are looking to engage senior leadership in this work and securing their buy-in, since it's so critical to success?
Oh, what a great, that could be our next webinar
Right.
together. Okay, I love it. So I think one of the key things is to build the capacity, leadership development. Most organizations have LDIs, leadership development programs happening. And hopefully even in the time of COVID, those are continuing. And this topic about how we can better engage and partner with patients and families, and very specifically, what's the leader's role, the senior leader, but also the mid-level. I think for senior level leaders, we have to convince them it doesn't take a lot of time, but they can integrate it in the way they work. And I think for mid-level leaders, listening to what it takes to build trust, to build research partners from diverse communities, that might be useful. I think to begin to think about it from like this conversation, we need to create a number of ways that they can build their skills to make it a priority for their organization.
Absolutely. And I agree with you. That's another webinar. So I want to thank you, Bev, for sharing your insights and expertise. It's always a pleasure to hear from you, to partner with you. I also want to thank everyone for joining us today. As a reminder, the webinar recording and slides and some of the resources that Bev highlighted during her presentation will be shared after we get off. To learn more about our upcoming webinars, you can look on our website and sign up for our e-newsletter and also follow us on Twitter. Have a good rest of your afternoon, everyone. Thank you.
Thank you.